Mesdames et messieurs, bonjour à tous. Welcome, ladies and gentlemen from all over the world. We're absolutely glad to welcome you to this 28th edition of the International Conference on Health Promoting Hospitals and Health Services. After Vienna, Bologna and Warsaw, we are glad to host this 2021 edition live from Paris and organized with a local host, RESPAD Network for Addiction Prevention. As you know, in order to give everyone the opportunity to participate despite the current health crisis, the conference has been digitalized and will be held in virtual format. My name is Marco and I will be your host throughout this whole conference today. This conference will focus this year on the development of health-oriented healthcare management systems and more specifically, how can health promotion optimize health gain and create more sustainable and equitable health systems. Throughout the day, renowned international experts will address the main theme of the conference in 2 plenary sessions. In addition, the conference will offer a rich program including 5 different slots consisting in 26 parallel sessions. And last but not least, you will have access to an exhibition room in 3 dimensions with more than 300 posters allocated in the different rooms. If you're not able to assist all sessions, don't worry, you will have the opportunity to post-stream the conference for the following 15 days. This means unlimited access to all plenary sessions, parallel sessions, posters and partners stands. Also, the chat function will stay available to allow 2 weeks of interaction between participants and speakers. We'll be together all day long from 8 a.m. to 4:30 p.m. Central European Time here in Paris, from 2 p.m. to 10:30 p.m. for our friends in Taiwan. I know that many of you are watching from there. Now that we have a better overview of our day, I'd like to introduce you to the 4 key organizers of this event, who will have a few opening words before we dive into the conference itself. I'd like to welcome first here with me in the studio our RESPAD local host. Here with me, Amin Benyamina, welcome.
Welcome, thank you.
From the World Health Organization, Natasha Azzopardi-Musca. Hello, Natasha. She's not here with us at the moment. With us from Poland, the chair of the HPH Governance Board, Bożena Walewska-Zieleka. Hello, Bożena. I hope I said your name correctly.
Almost.
And with us from Austria, the chair of the HPH Scientific Committee, Jürgen Pelikan. Welcome,
Good morning.
Jürgen.
Good morning.
Welcome to the 4 of you. So, as I said, I'm going to give the floor to each and every one of you to say a few opening words before we start the conference. So I'll start with you, Amin.
Yes, thank you very much, Marco. I'm going to take just a few words. Dear speakers and participants, I'm very proud and pleasant to introduce the 28th International Conference on Health Promoting Hospitals and Health Services. This year, the conference is taking place in Paris, in the beautiful city in Paris, and we are so delighted to welcome each of you to this annual global event. For this 2021 conference, the RESPAD, which is the French Network for Addictions Prevention and coordinator of the French HPH network, has been chosen as the local host to create and organize the conferences together with the conference secretary team. It is a great chance to introduce and get into more details on the topic of health promotion in France, where it is not yet so developed. The RESPAD has been working closely with the HPH network and the French network members for a few years to promote health promotion and huge healthcare services to change their point of view to empower the population on health topic. As the president of the RESPAT, I really think that health promotion is, one, a global topic, and two, and a standard to achieve in order to offer better health services to take care of both patients and healthcare professionals while including the wider society. Today, we're going to focus on the topic, development of health-oriented healthcare management systems. How can health promotion optimize health gain and create more sustainable and equitable health systems? It was an intensive work to offer a nice but virtual event to allow everyone to be part of it despite the health crisis. And we really hope that you will appreciate the various sessions and contents. We invite you to visit the poster exhibition room and to attend all offered sessions, plenary conferences, workshops, etc., etc. And we remind you that we'll have an access to all conferences, parallel sessions, which will be recorded and poster room during 15 days. I wish you all a constructive and inspiring conference, and I hope to meet you and all in person next year. Have a good conference.
Thank you very much, Amin, for these opening words. We're very happy to have you here. I'm going to give the floor to Natasha. Hello, Natasha.
Hello, good morning. Can you hear me well?
We can hear you very well. I feel like this is
very much.
Feel like this is Eurovision. I'm giving the word to different parts of the word. So, Natasha, the word is yours if you want to say something before we start today.
Thank you very much. And it's always really a pleasure to join you. And I augur you a very successful conference. I think we all agree that now, more than any time in the recent past, there is really an unprecedented understanding amongst the public, governments, the international community, that health is critical to well-being, resilience, and sustainability of our societies and economies. And now, as we look ahead to recovery and investing in the right kind of policies, we really need to learn from this past experience. The pandemic has touched all of us, but those who were already marginalized and at risk have been more badly affected. And I would like to draw your attention to a report that WHO Regional Office for Europe recently commissioned by the Independent Commission headed by Senator Mario Monti, former Prime Minister of Italy, called Drawing Light from the Pandemic. And basically this report touches a number of aspects, including the need to strengthen One Health, the need to ensure that our policies do not leave the most vulnerable further behind, to strengthen the resilience of our health systems, and to really make the case for investment in health at all levels and bringing a new type of governance for health at the supranational level particularly. Considering the focus of your conference today, I would like to touch upon 4 points and share with you some examples in terms of what we need to do to shift societies for health, well-being, and equity. And the 4 points I would like to mention are new models of delivery, new types of evidence, new technologies, and strengthening leadership capacities. In terms of new models of delivery, at our regional committee a month ago, we launched a paper that outlines the future of primary care based on the lessons that we have learned from COVID. And in a nutshell, we see that the future of primary care linked to hospitals, long-term care, mental health, and social care is multidisciplinary and multi-modality. Coming to new types of evidence, I would like to mention here the work that is being carried out by our Cultural and Behavioral Insights flagship. We need to understand what makes people engage with health systems, come for advice, follow the advice. Not least, for example, we are using this type of evidence to better tailor our communication strategies to address low vaccine demand and uptake in certain parts of the region. We need basically to re-engage and build trust, particularly with those who are least likely to trust science and health services. The third point is new technologies. Here, of course, we have seen incredible digital transformations taking place. The opportunities are immense, and yet we need to keep our eye firmly on the ball to ensure that we do not create bigger health divides between those who are digitally literate and those who are not, between those who have access to online services and those who don't. And in developing a roadmap for digital health in the coming months, the office will ensure that gender and equity and the rights perspective remains at the forefront. Finally, allow me to come to strengthen leadership capacities. And here it is great to see organizations such as yours really taking a strong leadership role. We need to come together because the problem is too complex and too challenging for any one sector alone to tackle. And here, allow me to share with you that 2 weeks ago, we have launched a pan-European coalition for mental health in the presence of Her Majesty Queen of the Belgians and the European Commissioner for Health and Safety. Why? Because what we had done before the pandemic was clearly not enough. And therefore, we need to build new alliances and really be able to foster leadership for mental health and well-being beyond mental health professionals, beyond people who are active in the mental health sector, but really engaging all of our clinical colleagues, because in order to fulfill the definition of health, we need to ensure that the focus is on both physical and mental health. And I think turning to the work that your association and your networks are doing in terms of the health promoting hospitals, there is really also a strong role that you can play by helping us to really place mental health and well-being on the agenda of hospital delivery, no matter what the health problem that people are presenting with is. So it's always a pleasure for me to make time to be with you, and I really wish you a successful event and look forward to our ongoing collaboration. Good day.
Thank you very much, Natasha, for these very inspiring words. I'd like now to give the floor to Bozena. Welcome back.
Thank you very much. Ladies and gentlemen, dear friends, on behalf of International Network of Health Promoting Hospitals and Health Services, and as a chair of GB of this organization, I welcome you at today's conference. You may read on our website that we promote and assist the advancement of the concept of health promotion in hospitals and health services and support implementation by developing structures, cultures, decisions, and processes. We regard this conference as a perfect environment for implementing this idea of HPH. The last conference, 27th one, was held in Warsaw, Poland, my home country. As you may remember, we discussed balancing the high tech and high touch in healthcare, challenges and chances of digitalization for dialogue. I enjoyed the discussions a lot as we live now in a digitalizing world and are in need to use IT solutions for improvement of health. We should use this solution as a patient-friendly and help keeping the patient in mind, keeping in our minds, the high-touch approach of health promotion, education, and support. Then it turned out that we live in VUCA world. V for volatile, U for uncertain, C for complex, and A for ambiguous. We've been facing pandemics for more than a year, And we face everyday challenges that require agile actions. I know everybody here face this and still operate in VUCA conditions. I want to express my deep respect for those who help patients on an everyday basis. They are heroes of our times. Thank you very much. The VUCA world is a challenge to not only to everyday medicine, but it is a challenge to health systems, including health promotion and health education. We missed conference in Seoul. I regret it a lot. Today we begin the 28th meeting, so the tradition is kept, however, in a different way. It is great that a solution of e-meeting was implemented. It shows that in spite of obstacles, we strive to develop the idea of ideas, learning from each other, developing the idea of health promotion in our home countries and across the world. Today we discuss the development of healthcare management system, how health promotion optimize health gain and create more sustainable and equitable health system. I would add that we need to develop health system and management policies from top levels to frontline and from frontline to top levels of management. Those policies that understand the role of health promotion and education as a substantial part of health orientation of healthcare system, which now is of utmost importance. It is not orientation only on highest quality of treatment, but the orientation on high quality education for high health literacy of patients and societies. I wish you all a successful day, lots of new ideas and best practices exchange, and inspiration from panel session. Again, have the inspiring day, and thank you very much for your attention.
Thank you very much, Bezina, for your insights. Let's move to our last organizer, let's say, Jürgen. Hello.
Thank you so much. Dear conference participants, dear colleagues and friends, welcome to our conference. It's a great honor and pleasure for me as chair of the scientific committee, as well as director of the WHO Collaborating Center for Health Promotion in Hospital and Healthcare, to open this 28th International Conference on Health Promoting Hospitals and Health Services, managed virtually from Paris. After last year's conference unfortunately had to be cancelled for the first time due to the pandemic, this conference is being held as a virtual event for the first time in the history of HPH to offer everyone the opportunity to participate in the conference despite the current health crisis. For this conference, the local host, together with the scientific committee and the governance board of HPH, decided to focus on the development and health-oriented healthcare management systems. How can health promotion optimize health gain and create sustainable and equitable health systems? This conference intends to show and reflect the contribution of health promotion in pursuing the goal of reorienting health services. Key elements that facilitate this reorientation of health services will be presented and discussed, with a scope ranging from governance models to reimbursement and outcome monitoring systems. Under this general conference heading, the scientific committee put together a plenary program with 9 top renowned international speakers and panel discussants representing academic experts as well as experienced HPH practitioners who will speak on and discuss with you the following 2 sub-themes: health orientation of health services by management systems, what and why; health orientation of healthcare services by management systems, how; models and standards of good practices. In addition, the conference will have a rich program of oral and mini-oral presentations, posters and workshops. The scientific committee screened almost 570 abstracts that were submitted by members of the global HPH movement from 21 countries and around the world, and almost 400 delegates have registered for this event. Of the submitted abstracts, 527 abstracts, or 92%, were finally accepted for presentation. 83 of these in 21 oral sessions and workshops, 42 abstracts in 5 mini oral sessions, and 399 abstracts in a virtual poster session. Presentation slides and posters will again be made available in the virtual proceedings at the conference homepage. You will receive an invitation to upload your files shortly after the event. And you can visit replays and content of the conference website during the next 15 days. Now let me warmly thank the many people and organizations who contributed to this conference. The scientific committee who supported the program development, the smaller scientific executive board we had for the first time, with whom we had 2 intensive and very fruitful virtual meetings, and on the program development, the plenary speakers, the speakers in the oral sessions and mini oral sessions, the poster presenters, and the people who will chair conference sessions. The co-organizers and sponsors of this conference, which you will find at the website of the conference, the team of the Vienna Competence Center for Health Promotion Hospitals and Healthcare, especially Birgit Metzler and Lisa Meyer, and above all, the local host of this 28th International Conference, RESPAT, especially Marianne Ochette and Nicolas Bonnet, who made a tremendous effort in welcoming us all to this virtual event broadcasted live from beautiful Paris. After the conference, we received an invitation to participate, which will be down and form encouraged to make use of it to support our learning for future events. Now, I wish you a fruitful and lively conference with interesting learning experiences and exchange with colleagues from all over the world. As we all had to learn in the last months, this can be done also to a certain extent, at least, in the conference. Thank you so much for attending, and to Francis Beck, my co-chair in the first plenary.
Thank you very much, Jürgen, for your words. Thank you to the 4 of you for your opening words, for setting the basis for this very nice day coming ahead of us. Let's now dive into the conference with our first plenary session. We will have for this 2 keynote speakers and a panel discussion with 4 panelists and 2 co-chairs, Jürgen Pelikan, who just spoke, who is already here with us, and François Beck, who will join him for this. This first plenary session will cover the following topic: health orientation of health services by management systems, what and why. The word is yours, ladies and gentlemen. I wish you an insightful and enriching session.
So good morning to all of you. It's a real pleasure and an honor for me to chair this first plenary session with Professor Pelikan. So I'm François Beck, head of the Prevention and Health Promotion Unit at Santé Publique France, which is a French national public health agency. So health promotion approaches have many features that in theory should make it effective, creating healthy settings at school, workplace, hospitals, sporting clubs, teaching skills. But in a time of scarce financial resources, we must make the effort to prove that health promotion investment give results on health indicators, and even show that we could have a return on investment without increasing social inequalities. So this plenary session will focus on health orientation of health services by management systems. And to address this complex subject, we are pleased to welcome 2 keynote speakers with 2 complementary presentations. The first will be given by Niek Klazinga from the Netherlands, who is the head of the Healthcare Quality and Outcome Program at the OECD in Paris. And he's also a professor in social medicine at the University of Amsterdam. And he will give us a systemic perspective on this topic. The second presentation will be given by Margareta Kristenson from Sweden, who is in particular professor in social medicine and public health at Linköping University and also have a great experience in family medicine and social medicine. She will give us a health promotion perspective. You will be able to ask questions after both presentations. And I now leave the floor right away to Niek Klazinga, who will tell us about the health system perspective from the OECD point of view. Niek, now the floor is yours.
Thank you very much, and thank you for inviting me to participate in this 28th conference of the Health Promoting Hospitals Network. The question I will try to answer in my contribution is in the title slide of my presentation. Why should governance models be health-oriented and balance health outcomes, ethical and economic aspects? And I will provide a perspective from the Organization for Economic Cooperation and Development. Here you see the entrance of the building of the OECD, which is actually located in Paris. And what I try to explain to you is that the philosophy that is behind the health promoting hospitals is actually perfectly aligned with the overall philosophy of economic development of the OECD. Within the OECD, healthcare is perceived as a part of the broader economy. That means that we're not just only looking at the costs of healthcare, but far more looking at what is the contribution of healthcare to the overall progress and development. Since the 18th and 19th of the 20th century, the key perspective that the OECD takes in the developing of economies is a welfare economics perspective, and that basically looks whether the economy is contributing towards the well-being of its populations. Of doing that, you want, of course, to have data. And that means that already for several decades, the OECD, when it comes to healthcare, is not just collecting data on the health of populations and the costs, but since 2002, has a program in place that tries to capture the quality and the outcomes of the healthcare systems. And actually, that program has been broadened by a mandate of the ministers of health of the now 38 OECD countries to also look at statistics that are based on patient-reported outcomes. So basically, from a system perspective, we try to collect the information that helps us to ask the question, how well are healthcare systems doing, and do they actually contribute to the health of the population? And as you can imagine, in the past year, a lot of work has been done on COVID-19, the impact on the healthcare systems, and at the moment, we're very much involved in discussions on the transition of the economies and inclusive the development of the economies after the pandemic. Many of this information is provided in a publication called Health at a Glance, and the next one will come in November. That very briefly provides information on all these different aspects of health systems. I won't go over all the details, but just to show you, this is a snapshot on health status, where we try to see for every country, not just what is life expectancy, but also look at chronic disease morbidity and self-rated health of the population. The other one is looking at risk factors. So it tries to address issues like smoking, alcohol use, where overall we see that it's getting better, but still increasing problems with respect to overweight and air pollution. A snapshot on the access to care, where we basically look at the population coverage of the financing of healthcare, the financial protection that is in place, the service coverage. And here you see we emphasize particularly the strength of primary care and preventive care as components that should address care before people end up in hospitals. We look at the resources, the spending share, but also the input in the system in numbers and availability of numbers of doctors and nurses. And as I said, we try to combine all these different types of informations on inputs and process towards looking at the quality and the outcome, and look at prescribing practice, the avoidable hospital admissions, the 30-day case fatality rates of hospital systems, and a whole series of indicators on cancer care. This gives a broad overview of what is available and can be used in the governance models in the respective countries. This aligns with a broader initiative that we see in a lot of European countries of governments working with health system performance assessment. And I'm just showing you the framework that Ireland agreed on just half a year ago, where basically you get information on your system and you try to govern by combining information on structure, process, output, and outcomes, and some cross-cutting domains like equity, efficiency, and surely now with the COVID efficiency, resilience. So let me go to the next one. How can you look at hospitals in the context of this system governance? First, you have, of course, to realize that hospitals are the product, or the modern hospital is the product of the second half of the 19th century, where institutes that provided care became modern hospitals through the technology that was introduced, like röntgen diagnostics and anesthesiology that made it a place where you could do operations. That initiated the professionalization wave we saw since the end of the 19th century and led to a lot of specialists and specialization that made the hospital an important part of healthcare systems in the 20th century. That overall development is now changing, partly because the underlying technologies are no longer the centerpiece, meaning that technology has evolved further, and a lot of the healthcare that was given in hospitals can be provided elsewhere, and digital possibilities and mobile interactions make it possible to provide a lot of the services out of the specific hospital building. Hence, the movement towards integrated delivery systems in the 21st century, and an overall development of organizational models where you are not speaking about just hospitals, but like in North America, accountable care organizations or delivery systems that try to combine all these components and look at the overall performance of the clinical services towards the health of the population. And that means that the incentives and the goals and the performance indicators should follow that movement. So when we look at the way how at present hospitals are governed and managed, and what are the accountability mechanisms, the kind of information that they provide, it includes a lot of information that is related to the relative contribution of hospitals to the overall health of populations. Here you see the classical indicators that are used at the moment, the 30-day case fatality rates, so mortality, morbidity and complication indicators, readmission rates that are look at the performance, but surely a big movement towards patient-reported outcome measures and patient-reported experience measures that not just take the episode of the hospital care, but take the broader approach of care pathways and long-term outcomes. And as stated, the more clinical data are complemented increasingly by person-centered outcome information. So if I have to answer the question why governance models and do contribute to the health of the population and why health promoting hospitals are a good idea, and I hope it's clear to you that that boils down to the fact that health services are there to provide health. Of course, health services don't produce health. They just help supporting people to optimize their own health situation. And increasingly we see that the available technology and professions should be organized in a way that is more towards integrated care delivery than just in the specific hospital. That movement is also a ethically sound approach where it balances the interests of individuals and the population, and as such adds value to the resources that are put in the healthcare system. So in that sense, also from the perspective of an economic organization like the OECD, health promoting hospitals are really a good idea because they contribute to the value of the system as a whole, and hence to a better development of our economies. Thank you very much.
So thank you very much, Niek, for this very comprehensive and clear presentation. And I will now give the floor to Margareta Kristenson for his presentation on more focused on health promotion approach. Margareta, the floor is yours.
Thank you so much for allowing me to speak on this conference. My name is Margareta Kristenson, and I'm a professor in social and preventive medicine, just as Dr. Klazinga. We are colleagues. And while Dr. Klazinga had the systemic perspective, I shall boil more down into the system. My background is family physician, and also I have been working in the HPH network as long as Jürgen for decades. I wanted to start by it doesn't work. Can you click on it?
We hear you now,
Yeah,
Margareta.
but it doesn't move. The challenges for health services, which we all work against, are changes in demography, more elderly, changes in the disease panorama with more chronic diseases. An increasing part of healthcare is repairing, not curing. Example, a hip replacement is only repairing, and after 15 years, we need to do it again. These also comprise multiple people with multiple diseases. We have new demands for the users, new knowledge and techniques within increasingly strained economy, which needs to increasing demands to develop a more effective and more proactive health service. And maybe someone wonders, is this new? When did this start? Well, these are exactly the same challenges as we had when all this started many years ago. This was actually the base for the decision to discuss the reorientation of health services. A health system which contributes more than before to the pursuit of health, written in the Ottawa Charter in 1986. So the vision of the HPH, which started at hospitals because we believed that the primary care was there after the Alma term, and now we know it wasn't. To have a more effective health service by reorienting health services towards health gain for patients, co-workers, and the public served. Health orientation. One discussion we had early on, and which we still have, is whether we shall talk about health promotion in hospitals or health promoting hospitals, because that is actually a difference. If we discuss health promotion in hospitals and have a health promotion activity in one of the departments and everything else is as normal, it becomes sugar on top of the cake. Instead, we need to have promoting hospitals, sugar in the cake, which makes the cake grow and develop. And this is about the health orientation. So now we have in the new WHO definition of health promoting hospitals and health services, we describe that they shall orient the governance models, processes, culture to optimize health gain of patients, staff, and population served, and to support sustainable societies. And the HPH concept, it works in 4 different perspectives. The main center is the patient perspective. And this is about optimizing effective health services by integrating health promotion and disease prevention in the care team. We do not do this so that patients do not have diseases decades after. It is to optimize the care at that very moment. And we know from Hanne Tønnesen, who demonstrates that smoking cessation before surgery reduces complications the week after. That is extremely effective, and the effect comes very soon. And also the encounter which gives a trustful and safe patient who believes it will go well has a better chance of surviving, because we lower the vulnerability and strengthen the resilience. We discussed the co-worker's perspective is about to become a model for a health promoting workplace. If we work at health as our mission, we need to take responsibility to actually use our knowledge to develop the best possible work environment for our workers. And that is not always the case. The population perspective is still our weak part, and we need to do this more to support public health interventions for the population served and in local communities. And Halfdan Mahler, in one of the pictures from the early days, he sort of broke the walls of the hospital to open towards the society. And that is what we need to do even more. But not least, the management perspective to enable all these activities and to use health orientation as a means to become a more effective health service. And then how is that? This is a picture done by a colleague of me, Bo Busham, from Stockholm, who demonstrate the way through the health system, where people's health determinants, whether you have risk factors such as smoking, such as earlier diseases, such as social isolation, which makes you more vulnerable. If you have more diseases, what kind of disease you have, which defines your needs. And then the affordability of care, the accessibility of care defines the demands. And as he's a very kind man, he says, in the best of worlds, the individual consumes the health care which leads to the best health outcome. This is health orientation. Then what is health? Well, I want to remind you that health is not only lack of disease and infirmity, it's also physical, mental, and social well-being. And as Dr. Klazinga just mentioned, this is necessary we can measure it. Health-related quality of life, we can measure that via EuroQual or SF36. And this can be done and is today, I'm so happy to hear that it's done by OECD, but in ordinary practice, this is still rare, but it is necessary. Patients reported experience measure to identify patients' perceptions of the structure and the process, but also reported outcome measures to analyze how people report their experience of the outcome. When I was chief of primary care 30 years ago, I was confused and frustrated that they only looked at my productivity, how many visits we had per hour, and how many patients we saw. And they discussed this in the terms of effectiveness, which I didn't understand and which actually was not correct. Today, we still are very focused on productivity, and we focus on how many things are done and DRGs, etc. And we need to come towards effectiveness in its real sense. And do we measure health gain outcomes as a part of health service? Yes, of course we do. But is this the main driver today? Not always, because the main driver in many health services is economy. The economy, the bottom line for many health services is economy, and many of my colleagues, the economy is the main thing they ask for. And while both politicians, patients, relatives, professionals, and everybody want to come towards the health outcome, the economy becomes the aim and not the mean. So what we have to do is to use economy as the means for health gain. And this is possible, but we need to be careful. And this is the model for need-based governments, which we are working with in Sweden, where you can see in the upper big model is how we use population health status to define the needs in the population. And based on this, we define the activities needed to be done, and which is governed not today by evidence-based governance, but maybe by knowledge-based governance. And in the next phase, the productivity governance. And the feedback loop back should need to go, including health outcome assessments for continuous improvement and learning. And if this is done, not only back to purchases and managers, but also back to the activities at the ward for learning, this can both lead to a more effective health service, but also to a learning organization where people expand their capacity, create the results they truly desire, and learn together. Personal mastery, shared vision, and team learning. And this is the essence of the health promoting workplace, where the balance between demand and control at work, where I want to remind you that control is not only about decision latitude, it's also about intellectual discretion to learn and develop and feel that you are doing something important and can invent new things. So to conclude, health orientation, using health gain measurements as a tool for health service management and health policy can optimize health gain on patients, staff, and population served, and create more sustainable health systems. Thank you.
Thank you very much, Margareta, for your very interesting presentation. And now I leave the floor to Professor Pelikan to chair the question and answer session.
Thank you so much, Dr. Beck. I will take over, but I have to ask Marianne, are there already questions from the floor? Do we have questions from our participants? Thank you for the question. Niek, what is your answer to the question, please?
Thank you. If I understand it correctly, the question is what type of indicators on hospital performance in relation to health promotion does the OECD have? As I said, the indicators we work with are mainly on a system level, but of course we try to link the classical health and risk factor information that I showed with what is available in administrative systems on readmissions, mortality, etc. What we try to capture is basically the elements that Margareta Kristenson also mentioned. We look whether the organizational models are actually looking at the population as a whole. So is there a movement in a country from isolated hospitals toward integrated delivery networks? Do we have accountable care organizations or other networks of service providers that take the population as a whole. So that's one of the sets of indicators. Is that development ongoing? And we look very much on whether countries have the intelligence, the knowledge to use the information. And that can be, for example, in the purchasing policies of insurers, where when they make a contract with a hospital, they look at health promoting activities, and they look at changes in health status. And a very important one that has been entered in the past 10 years, and Margareta Kristenson also referred to that, is the development of PROMs and PRAMs. So we start asking, do you have it? And from those pockets where we have the information, we try to collect it. And luckily, there are some international standardized PRAM surveys in outpatient care that include questions on an experienced information that was provided, and when also questions like, do you feel that you can manage your own healthcare? So we have that kind of intelligence. With the PROMs, we are at this moment, on the one hand, working in 3 areas. We look at breast cancer, hip and knees, together with the national registries, and in mental health, where Denmark is actually leading the work. And we have a new part of PROMs development ongoing at this moment in 20 countries that focuses on the experiences of patients with treatment of chronic diseases in primary care. So we try to balance the very clinical oriented PROMs developments that many countries have with an approach in primary care. It's a little bit lengthy answer, but it shows the different types of activities that are ongoing within the OECD to promote this way of change.
Thank you, Nick. An excellent answer. And we see that at least monitoring systems at the national level are going more into the direction of measuring indicators which really measure health of populations. Are there other questions from the audience to Nick or Margareta?
I see one on the screen, and that kind of follows up on what I said. It reads, OECD collects PREMs and PROMs. Could you please elaborate on this? That's what I did. And comment on how this data collection may need to better reflect health gain in the health system. It would reflect the health gain in the system better if this was introduced on a large scale. And where we are now is that both hospitals and also financiers, in using it in contracting, are starting to do it. We don't have this available in all systems wide. Margareta might relate to that, but what I know from PROMs use in Sweden, it's pockets in different areas. It's not system wide, but the development is there. So what the OECD does instead, apart from promoting it and having theme-based action programs, we are also looking in countries how they embed this information in their regular data infrastructure, because that is the next problem you see. It's nice to collect it once, but it means you need a data architecture where people in a systematic way provide information, and that information should end up in the regular data collection and should actually be presented in such a way that citizens have ownership of the data, so they can use it in the consultation with the doctor. But we are still developing that, and we're not yet in a situation where that is introduced everywhere, so that we can aggregate and give you the results. But we do monitor what is happening and report that in our publications.
Thank you so much, Dick. We see it's one thing to have a good normative system, and another to implement it in at all levels where it's necessary. There's a question to Margareta as well. Margareta?
I think the question is that I mentioned that performance is still largely assessed by addressing healthcare outputs in economic terms, I think. What is the main factors why managers don't put more emphasis on the health promotion outcomes? It can't be only the macroeconomic financing and reimbursement systems and health service. And I think this is the key question of today. And we are in a system where economy is always strained. We have continuously increasing demands, and in ambitions to create more cost-effective health services, the economy is the frame, and sometimes often is the aim, because that is what our managers are looked at. But if we can use the health outcomes more systematically and use these as a measure for good performance, we will have another kind of dialogue. What economy is the frame, again, but the health output is the target. I think to do this, we need to more systematically monitor in ordinary practice, not made only for individual encounters, but also for the quality improvement models, so that like we evaluate whether we have the best treatment for the hypertonic patient in terms of blood pressure, we also measure health-related quality of life for patients. And we have the means and we have the capacity. So it is necessary that you, as purchasers and managers, ask for it.
Thank you so much, Margareta and Niek, for your presentations and for answering first questions. But I think now we have to go to the next part of this plenary. We have invited 4 panelists, and I would like to give the panelists a chance to offer their first statements. And if you allow, I would like this time to start not with someone in the hierarchy of the system, but with Klaas Röhl. Klaas Röhl is president of neurofibromatosis for children and presidents of other patient associations concerning that. And I think we should start with him to give a patient a first perspective on what we heard from our 2 presenters. The microphone is yours, Klaas.
Thank you very much for the kind introduction. Coming from a patient advocacy background in rare diseases, I would like to focus my comment on data. I think a health system that is health-oriented needs to be a smart system that is driven by high-quality data. A smart system that is highly reactive and flexible. A smart system that aims to keep every person in it safe and well. If you allow me, I would like to draw a comparison to actually safety in air travel. Air travel is one of the safest means of transportation because there are over 1,000 sensors that continuously send data in real time to the cockpit, so that at any time you can check if the systems are working properly and what position the plane currently has. In case of an incident, the pilot applies the emergency procedures as he or she was trained to do to make sure that the passengers reach their destination safe and well. We need a smart health system that continuously collects meaningful data in and outside of the hospitals. Medical records, but also real-world data. Hard endpoints like lab reports, but also patient-reported outcomes. Actively and passively collected, so that we understand where the patient is traveling in our health system and how he or she is doing. A smart health system needs to be asked the right questions so that the answer allows us to react quickly enough to prevent harm when possible. A smart health system needs to learn from its mistakes, constantly evaluate itself and make improvements. It has to understand the needs of the patients. A smart health-oriented health system makes the patient a co-pilot of their own health. It doesn't only collect data from the patients, it gives direct feedback to them about their own health and empowers them to make the right decision in order to maintain or improve their own health. It teaches them to take responsibility of their own health and educates them so that everyone understands that decisions are made on the basis of evidence emerged from data that is collectively generated. A health-oriented health system makes sure that every person in its system can reach their individual goals. I'm afraid that in today's health systems, there are still cases where a patient travels through the health system totally blinded, with all systems failing and with no orientation and no contact to the tower that can provide guidance, with no emergency plan. And when the patient's health crashes down, it is probably the result of a long chain of bad decisions that led to this worst case scenario. So a health-oriented health system needs the people to become active partners, to become co-developers and expert advisors. It sees patients not as the problem, but as part of the solution. So a health-oriented health system needs all stakeholders, patients, health professionals, researchers, regulators, HTA bodies, industry, etc., to work together to agree on how the data is being collected and how the system can be further improved. It involves continuous training of all players to reach better health outcomes. Instead of focusing on the short-term investments, it should focus on the long-term achievements that a health-oriented health system will bring to its people. Thank you.
Thank you so much, Klaas, for giving us a smart perspective how patients can be integrated in a smart system. And I think that is a good explanation also for what Margareta was talking about, learning organizations. Yeah, we need learning systems. They have to be smart and they have to take the perspectives of all stakeholders into their working. And of course, co-production is a challenge, but there are means of how doing good co-production. Thank you much for your input. With that, we go to our next panelist. Our next panelist is coming from political authority. It's Dr. Carmen Cabezas. She's Secretary for Public Health, Department of Health, Government of Catalonia, Spain. And she's a specialist in family and community medicine and preventive medicine and public health. Carmen, the floor is yours, or the microphone is yours. What is your perspective on what we heard from the two presenters, please?
Good morning, dear colleagues. My point of view is from the public health and the governmental point of view. The idea is that I think health systems and thereafter its governance should be health-oriented, of course. And I think that my point of view is mainly focused in the populational perspective. When Margareta Kristenson said before that we have to put into the equation this patient-centered point of view, but also this populational point of view, I think that health systems are part of the society, and we have to work together with the other sector of the society in order to improve the health of the population. For instance, the health of the population is not related mainly with the health sector, but also with other parts of the society, with the education of the people, with the income of the people, with other factors, for instance, the environmental issues and so on. And for that reason, we as a health system have to work with the other part of the government and the society in order to improve the health of the population. And from the point of view of the health promoting hospitals, it's very important that when the professionals are treating the patient, they put in practice this holistic approach, and they try to not only to cure the disease or to treat the illness, but also to have this holistic approach and to work together with the patient in order to improve their health. But also, it's very important the fact that hospitals and health centers are part of the community, and they work together with the community in order to improve the health of this society. They work, for instance, in this pandemic here, they only not have been treating the disease, but also have been working in vaccinations in order to improve the health literacy of the population living in this part of the city, and working together with them in order to improve their health. In Catalonia, we have been working with the health promotion hospital network for many years in this type of approach, and also we have been working in this relationship with the community in where they are located. And I don't know if I explain myself very well, but the idea is that the health system is not only dedicated to treat diseases, but also are an important asset of the community, and work together with the community in order to improve the health through the work in all the determinants of the social determinants of health. Thank you.
Thank you so much, Carmen. I think it was especially important that you stressed the healthcare system has to interact and cooperate with the community, and how important the community is, especially if it's about prevention and health promotion, as we said, saw in the COVID pandemic. But you are quite right. If we want to improve population health, the healthcare system all the time has to interact and cooperate with the community. Now we had quite some speakers from Europe, and therefore I'm very glad that our next panelist will be Professor Yingwei Wang. He's professor now of Tsinghua University, Tsinghua General Hospital, Taiwan. Yingwei is an old friend of us. He's a former director of general health in health promotion administration in his Ministry of Health. He's a former secretary of the Taiwan Network of Health Promoting Hospitals. And he's a man who initiated and supported all the time the strongest HPH network we have in our community. Yingwei, very welcome here. What is your comment from your perspective on what we heard from our two presenters and the two panelists till now? Yingwei, the floor is yours.
Yeah, thank you for your introduction. I'm really happy to share my experience. As you mentioned, I'm the former Secretary General in Health Promotion Hospital Network in Taiwan. We noticed that in Taiwan that there are none of most of the 100% of medical centers join the health promotion network, and 90% of the regional hospitals join the regional health promotion network. So that means that we are very engaged in the health promoting hospitals or health promoting health service process. Getting what Margareta mentioned about the concept of productivity. I think that's very important, that the mindset is very important. We are talking, I just want to mention as the three levels, the macro level, the meso level, and the micro level. For the macro level is from the governmental levels. And also there's a lot of incentive to promote hospitals to join this program. And also help promoting hospitals to integrate into the healthcare system. And also that there are none of, and another way is about the accreditation process. We have some encouraged the hospital to join the accreditation, and then they make that think that this is an honor to be one of the higher promoting hospital in their service. The second one is about the meso level, is the hospital levels. I once gave a presentation and the people said, don't say too much, just give me 2M. The one is the money, the second is the method. The money is the incentive, so we have the incentive. And how about the method? And so we developed some of the workshops, and also as Ergen used the, so as Kairos mentioned about the patient, the engagement. It means that the patient of the staff engagement is very important. And the engagement related with the health literacy. So we've started health literacy in the organization and engage the people to understand the importance and how to apply it to the health process. And the third is about the personal levels. And we are a lot of also some training program and also integrate into the healthcare system about the preventive service. So as I mentioned that money is very important, method is very important, and also the monitoring, the 3M, the so-called accreditation is important. But finally, I find that the fourth M is most important, is to change the mindset. As Margareta mentioned that in the past, most of the people looking at the productivity of how to care, how many patients they kill or care. But the health promotion is different aspect. So we need to change the mindset of the government and also the leader of the hospitals. So for us, the 4M model is very important. The money, the method, the monitoring, and also changing of the mindset. That means that we can encourage people to engage, and also we feel that it is important to be health promoting health service. Thank you.
Thank you so much, Ying Wai. I think what we really can learn from Taiwan is that to change things on the meso level of hospitals and healthcare institutions, it is necessary that these are supported by the National Ministry of Health and by the national governments. And as you said, they have to be supported by many M's, most important by methods and by money, and of course by the mindset. And we see that in your country, you really were very successful with this strategy to really make many of your hospitals and healthcare institutions health promoting healthcare institutions. Therefore, what we need is enough support by governments to reorient health services into this kind of direction. Of course, much can be done at the meso level by the people working there and by the staff, but they only can do it in a systematic way if they are supported nationally by programs, by money, and by methods. Last but not least, panelists now will be Boshena. You already heard Boshena. I don't have to present you, but Boshena, what is your perspective as somebody who organized for many years the Polish network and who was the chair of our governance board and who has a long tradition as Ying Wai in health promoting hospitals? What is your reaction on the two presentations and maybe on the three panelists before you? Boshena, the floor is yours.
Thank you very much, Jürgen, for letting me speak. First of all, I would like to thank both speakers for tackling issues that are very important for contemporary health system. OECD report is, for me, a kind of Bible of knowledge about health system in OECD country, because the report provides data to compare. And when I hear the panelists and the lecturers, I still keep in mind that we have this triple aim of health system that needs to find balance between economy, quality, and patient satisfaction. Now we think even of quadruple aim, where healthcare workers are included. It's not only patient satisfaction, but health workers' satisfaction as well in the whole system. I will address the issue very personally because I thought that I might show how the health promotion in my country is implemented. When I mentioned the healthcare worker satisfaction, I need to tell that if you look at OECD report, we as a country, we are, I mean, our workforce and composition of the workforce is far, far below any other countries in Europe. That means we have like 2.5 doctors per 1,000 population and a little bit over 5 nurses. So the everyday work overload for healthcare workers is much higher than in many European countries. Therefore, expecting extra work from them dedicated directly to health promotion is dependent on rather staff engagement and very personal attitude than the system itself. And therefore, I strongly support introducing stable procedures and processes that will help to implement health promotion on all levels of healthcare system with support of public health specialists and educators. Or if we think of healthcare workers, the organization of healthcare workers, of the work of them should be improved. Moreover, the system of incentives in my country should be modified, as so far it reflects the priorities of health policy makers to manage the health system towards gaining and keeping better health. The incentives are directed now rather toward reparative medicine, or if financed the primary care, it is usually a place where well, our manager can think of reducing the use of the system, and therefore is not effective in an aspect of health gain of our population. Yes, neither, because we have a per capita incentive in primary care. This does not allow the flow of the incentives toward any activities in healthcare promotion or healthcare education. That means if it does not, if they are not dedicated to this area, they are not used in this area, and this is very worrying situation. I would say that the coordination of care is still poor. However, there are already some works on the governmental level and from the ministry and via our NHS to provide coordinated care. It is still segmented, but the work on that started. Hospitals are financed again by our central NHS by the number of contracted procedure. So this is clearly a reparative medicine, and whatever we find in the hospital as the teams for health promotion and for patient education, they are running, I think, mostly by understanding of the managers that it pays to give patients enough education and enough help to help the patient to recover. Many hospital managers understand the role of the hospital in society it serves, so being the center of excellence, education, and health promotion in society. But it's not every hospital. What works pretty well is healthcare worker to person health advice. Strangely, because I mentioned that we do not have much healthcare workers and our needs are much higher, but still human-to-human touch works the best. And the hospital that receive quality, any kind of quality certificate should provide the proof of patient education about health risk in his or her disease. However, this is a bit too late, because when the patient is in the hospital means that the health deteriorated. However, it's good to have this advice, because it may improve the prognosis of the disease. I wouldn't like to prolong my speech. However, we have to, the intervention in patients' health habits is not standardized nor widely used. It's rather segmented, being organized by different stakeholders on different levels of administration, by hospitals, or by any non-governmental organization. And this raises the issue of health inequities. Big cities versus smaller cities or countryside, because then those activities are mainly in big cities. And again, there is a annoying inequity taking into consideration the level of education. What I found out that the gap in the life expectancy at age 30 between people with the highest and lowest level of education in Poland in men is 11 years. I wouldn't believe, but this is something that is really of concern. And I truly believe that this is the signal that the health education should start not in the hospital, but much earlier. I may say that already many our companies, big companies especially, started the health promotion by well-being teams in those companies, working for the workers and for their families, which is again quite interesting symptom. Of course, healthcare systems should be health-oriented, as health of the society is the value for money. To measure the effectiveness of health-oriented health system, we should use indexes presented by Margareta, which are very close to my heart, and they are my personal interest. However, we do not have this widely used in our country so far. Of course, proms and prems in ambulatory care would be a kind of challenge, but it is still to be implemented. I would say that our private sector is doing much better in this than the public one. Minister of Health prepare legal act on quality in healthcare. First,
sorry, Božena, I think you have to come to an end, please, okay, because time is running quickly.
Absolutely, yes. So what I would, since we spend 3% of the country health expenditure on health promotion to prevent non-communicable disease and 96 on treatment, we have still a long way to go. But I think that first of all, the trans-sector cooperation is needed. So to gain health literacy of our people, we should start from education, so Ministry of Education, then the Ministry of Work and Social Policy, and then Ministry of Health. So trans-sector cooperation is needed to gain health literacy in this society. Thank you very much. Sorry for prolonging my speech.
Thank you so much, Božena, for sharing with us a very concrete example of health promotion in healthcare in Poland. Are there any questions to the four panelists from the audience? Are there questions? Yes. How can a smart system still be culturally appropriate? Is that the question? Yeah. Who wants to answer this question? How can a smart system still be culturally appropriate? I think smartness was brought in by Klaas.
Yes, well, I think the smart system would also be able to be appropriate culturally and adapt to the needs and the cultural needs of the population in that health system. So I think that basically is my understanding of a smart system, to understand the conditions in the country, the needs of the patients, including the cultural needs, and maybe that means to have a different approach when it comes to communication with the patients. So yeah, I definitely think that a smart system can be appropriate culturally.
If I understand you correctly, a smart system would be culturally sensitive. Yeah. Are there other questions to our panelists? No question. Are there questions from panelists to other panelists? Do we have questions to each other? Not at the moment. Why, please?
I think in response to the smart question, the smart system should be very smart. And also the people that use the smart system should be smart. Because we noticed that even for the digital era, that even the elderly, they can use it. And there's always is a two-way dynamics. The user and the provider, they use them both very smartly. So the system should be very smart.
Thank you, Why? I think with that, we have to come back to our two presenters and give the two presenters the final comments. And I would ask first Niek to give his comments when he heard the discussion and we heard the contributions of the panelists. What is your reaction to that?
No, thank you. And I'm very happy with the discussion. And again, it underpins the remark I made earlier that the thinking in the network of health promoting hospitals is very much in line with the overall thinking about economic development that should be focused on creating welfare. I'm particularly happy with the remark from Klaas about the digitalization and smart healthcare. That's what I try to adjust. That's exactly where debates are going at the moment. So the OECD has a lot of discussions on the digitalization, and especially the point you try to make. If you do that, there should be ownership by patients. The data should be in the public domain. So on the one hand, there are discussions of keeping that out of the commercial domain, but especially also with introducing things like prompts and prems, making sure that it's used by people themselves, that they use it in the consulting room. That's where you create value. Again, healthcare systems don't produce health. People produce their own health. And if you empower them by having the data, the intelligence to really have a meaningful dialogue to get the right advice, that's the way how it should develop. So the OECD is really pushing countries on going in the direction of prompts and prems, but building that in their data infrastructure.
Thank you so much, Niek.
In such a way that it can actually be used by patients to create value for themselves.
Thank you so much for your final words. Last words will have Margareta, that we can close in time. Margareta, please. You very much wanted this kind of plenary. What are you saying at the end of it?
Well, I'm very happy. I feel that we all agree and that we work from different points. But to me, one of the most important words now was by Yingwei, saying that we need a mindset, change of mindset, that we remember, everybody, that we are not here to make money. We are not here to do as many things as possible, but we are all here to give the best health gain for patients and populations. And the beautiful thing is that this is the shared aim by everybody. Johannes Wang, our old teacher, he always taught me this, and it's true. Politicians want health outcomes gain, doctors patients, relatives, and also purchases. They want to create health gain within a good economy. And the good thing is that we now have better means to follow outcomes, not only in terms of mortality or morbidity, but also self-reported health gain. And the co-production named by the patient representative is of course the center, so that these feedbacks loop go back to the ordinary practice. But there was a system whether we should use prem and prom on individual versus group basis, and also on the group basis for the working team to look at, for example, patients with chronic disease, obstructive disease. As a group, are these getting better, and who of these are getting better, and what should we do instead? Again, to have the learning back at the bottom. And the final point I wanted to say, Carmen talked about our work outside. Also, a very old picture of HPH is a coin with two sides. One of the sides is about health-orienting health services to become more effective services. And there we need to go from productivity to health outcomes. The other coin is to really use our knowledge, our prestige to improve the public health interventions to the society. And we need to work on these both sides, working at the same aim, which is health gain. Thank you.
Thank you so much, Margareta. Thank you so much, Niek, and the four panelists. I think we had a very interesting start of this conference. Of course, the right topics were brought on the agenda. Of course, we couldn't discuss all of it, but I think the discussion will go on in all the sessions. And as you know, for 15 days after this conference as well, you can by chat discuss these very important topics for HPH further. Thank you very much. And now I hand over and close this session.
Thank you very much to all of you, to all of the speakers for this very insightful discussion. We've started the day the best way possible. We are going to do now a small break, 10 minutes break. So at 9:40 Central European time, we'll be back here. It's going to be 3:40 over there in Taiwan. Just so you know, you can connect to the platform, to the program tab of the platform and access. We're going to have 3 different slot sessions coming up before the second plenary. So we will start at 9:40, the first slot session with 6 parallel sessions. In the meantime, if you want to enjoy your break, go to the chat. We've posted 3 links to videos for which you can enjoy your break with some movement videos for you to enjoy your break. Thank you very much. I'll see you later for the plenary session at 1.